And so I'm here to present my research today on modeling the clinical implications of andexanet alpha and factor Xa inhibitor-associated ICH. And these are my disclosures, and these are the learning objectives. We'll talk about factor Xa inhibitor-associated ICH and the reversal mechanisms, modalities for it, and then how we modeled the clinical implications of andexanet alpha. So start out by laying the clinical question, which is that andexanet alpha is a new factor Xa inhibitor reversal agent meant for emergency bleeding. And you can see how it works in the upper right-hand corner as a decoy protein for factor Xa inhibitors like apixaban and rivaroxaban. And the Nexa-4 study was a single-arm open-label study that led to its FDA approval in 2015. But importantly, it lacked a comparison group, which current standard of the care at the time was PCC or Kcentra. And it also used bleed expansion as its primary outcome, rather than something that was more clinically relevant, such as modified Rankin scale at discharge or at 3 months. So it left a lot of clinicians wondering about, when they should use this drug, because the drug was extremely expensive. It costs about $27,000 a dose. So a lot of clinicians were wondering, we don't have data, randomized data comparing it to standard of care, PCC. And we also, have bleed expansion as the primary outcome of this study rather than something more clinically relevant. This becomes even more of a topic for today because there were the recent AHA-ICH guidelines, which came out this year, which suggested both use of andexanet alpha and PCC, but the fact that there is no randomized data, as you can see in this column right here. So that really led to the impetus for this study. And I'll spend some time going over the methods because I think that's what's particularly innovative and really interesting about this study. So we started with our original data set of about 600 patients who presented to Rhode Island Hospital with an ICH. About 10% of them were factor Xa inhibitor-associated hemorrhages. We then created a bleed expansion prediction model, which is the IH prediction model you see here, such that for each patient, we could calculate the probability of bleed expansion. We then created an outcome model, which used bleed expansion probability as one of the inputs into the outcome model, such that for each patient, we could now both calculate the probability of bleed expansion and reliably predict their outcome at 3 months. From there, we created a simulated factor Xa inhibitor cohort, taking our original cohort and simulating if they were all on factor Xa inhibitors. And we then recalculated their bleed expansion probabilities. Now we could modulate, dial down and dial up the probability of that bleed expansion and feed it back into the outcome model, such that now we have two groups, one with no change in their bleed expansion probability, which is the current standard of care with Kcentra, versus probability decreased by 1/3 or 1/2, and compare those groups to get absolute risk reduction, number needed to treat, and cumulative cost. What's innovative about this and what was really cool was that the clinical benefit of andexanet alpha is meant to be caused by decreasing the probability of bleed expansion. And so by modulating that probability, we're able to calculate the clinical benefit of this drug. And so this is our table 1 of our patients. And you can see about 10% of them use factor Xa inhibitors. And these are the two models. And you can see that both of them had really relatively high area under the curves. And I don't think that's particularly surprising, given that we use established predictors for both bleed expansion and for outcomes. You can see that the outcome model, really is very similar to the ICH score, except it uses bleed expansion probability as one of the inputs into the outcome model. And you can see factor Xa inhibitor use as part of the bleed expansion model. And these are our results. You can see at 1/3 reduction in bleed expansion, an absolute risk reduction of 5%, a number needed to treat of 22, and a cumulative cost of about $500,000. And at a 1/2 bleed expansion reduction, you see an absolute risk reduction of 7.4%, a number needed to treat of 14, and a cumulative cost of about $350,000. I've been told to contextualize these values. So in terms of years of tuition at UW School of Medicine, it's about equivalent to 9.8 and 6.5 years of tuition, respectively. So you can see in the figures in the upper right, the bleed expansion probability. Naturally, as the probability of bleed expansion goes up, more likely to have an unfavorable outcome. And as you reduce that bleed expansion probability, there's a greater benefit of the drug. And we also performed 2 analyses, one with patients who would have been enrolled into the Nexa-4 trial, matching our cohort, and then those who would not. If a hospital were to include andexanet alpha in its formulary, it's very probable that patients presenting with ICH who would not be eligible for the original trial would still get the drug anyway. And naturally, you see a higher number needed to treat and higher cumulative cost for this non-eligible cohort. Again, in these figures, you see as the bleed expansion probability decreases, lower numbers needed to treat and lower cumulative costs as well. So this study was really critical to our hospital's discussion of whether or not to include andexanet alpha in the hospital formulary. We ultimately at Rhode Island Hospital decided not to include it, given its lack of, clinical benefit that's been demonstrated by randomized trials, and relatively high cumulative costs, which we showed with this simulation study. Some studies have found a mean hospital reimbursement for an ICH is about $11,000. So if you're giving a $27,000 drug at the get-go, one has to carefully weigh the risks and the benefits of that. This study is also even more important, given the ongoing discussion about the roles for surgical evacuation of hematoma, with the recent AHA guidelines suggesting perhaps an increased role for hematoma expansion, for hematoma evacuation, especially with IVH. I think another important discussion point is the cost of PCC versus andexanet alpha. PCC costs about $4,000 a dose, roughly, versus andexanet alpha. And while that pales in comparison, it's nothing to sneeze at either. The limitations of this study, it's definitely limited by the fact that it's a simulation study, and we had a relatively smaller cohort of patients with inefficient hemostasis or bleed expansion and with factor Xa inhibitor associated hemorrhage. Other areas of interest definitely want to look at, if andexanet alpha is used for other neurosurgical pathologies such as subarachnoid, subdurals, epidurals. It gets a little tricky because those patients go to surgery much more often, and that kind of fuddles with the groups and who would receive andexanet alpha. I'd like to thank the many collaborators who contributed to this project, and I'd also like to thank the UW Neurosurgery Department for hosting me for the past 4 weeks. It's been a blast. If you'd like to read the paper, this is the citation. Thank you.
Carlin, thank you very much. Any questions? Just speak up if you have any questions, because I'm not seeing any hands just yet. All right, Christoph, I see the clapping, going through the list. No questions from our vascular. Okay. Well, thank you very much. That was well done, Carlin. Daniel, I believe you're next up, and you're sitting just sweet seats. Thank you very much. And Dan, why don't you tell us about you?
Hey everyone, I'm Dan. I'm from UCSF, and one fun fact is that I do triathlons. So I've done like a number of triathlons. My best event is running, and my worst is definitely swimming. So,
well, that's nothing to be ashamed of. That's impressive. All right.
Can everyone see my screen?
I cannot see your screen yet.
Okay.
Just try sharing it again.
Yeah. All right. Can we see it now?
Yes, I can. Very good.
I'm just going to turn slideshow mode. Great. All right. So today I'll be talking about research I did in Dr. Phil Starr's lab at UCSF, focused on deep brain stimulation for Parkinson's. And this is the primary work that I'm going to be talking about, which is chronic sensing of subthalamic local field potentials, comparison of first and second generation implantable bidirectional systems within a single subject. I'll be talking about some extra work that we did in the lab as well. But this is the primary work. So a bit of background. As we all know, deep brain stimulation, or DBS, is an effective treatment for a number of conditions, including Parkinson's disease. However, DBS typically doesn't take into account the variation in disease state that occurs from moment to moment and day to day in Parkinson's disease. Adaptive deep brain stimulation offers to improve on this by modulating therapeutic stimulation based on sensed electrophysiologic activity. So we can see a schematic of that here, in which neural activity is sensed from the brain, used as a control mechanism, and fed back into adaptive algorithms that modulate therapy based on sensed biomarkers. One potential such biomarker for Parkinson's disease is beta band activity. So depending on the source that you cite, roughly between 8 or 12 to 30 hertz of activity within the basal ganglia has been associated with Parkinson's disease and is a potential biomarker for adaptive deep brain stimulation. Further background, so initially electrophysiologic sensing from deep brain structures was only possible intraoperatively using microelectrode recordings, which we still use today to intraoperatively to determine correct lead placement, however, is obviously not amenable to adaptive deep brain stimulation. We were then able to record perioperatively, and some adaptive algorithms were able to be implemented for Parkinson's in this way, but this required significant digital amplification as well as externalizing leads not amenable to adaptive DBS. Finally, we were able to perform bidirectional recordings with the actual implantable pulse generator in the chest, both delivering therapeutic stimulation as well as sensing electrophysiologic activity from deep brain structures, obviously making adaptive deep brain stimulation now possible. So for this work, I focused on one patient, a 42-year-old man with idiopathic Parkinson's, who received left-sided subthalamic nucleus DBS with sensing capabilities. That's shown here in this axial T2 cut through the level of the subthalamic nucleus. Left is left and right is right in this planning software. And we can see the STN, or subthalamic nucleus, identifiable as this T2 hypointense structure here with the lead in place. He also received right-sided DBS without sensing capabilities. He was initially implanted with the bidirectional Medtronic Activa PC+S, and when this was at end of life, this implantable pulse generator was replaced with the second generation Percept PC. So we can see a schematic of what was changed here. The implantable pulse generator was the only thing that was changed. All of his brain leads as well as stimulation parameters were kept the same. So we have a control between the first and second generation device. For methods, I won't belabor them, but we recorded local field potential activity from STN, both with the first generation PC+S and second generation Percept. I filtered this raw time series data for artifacts and analyzed the data in the frequency domain. And jumping into results, this data is shown with stimulation off and in the medication off state, essentially in the natural disease state. We can see this very strong beta peak at around 20 hertz. That's consistent at months 3, 7, and 11 with the first generation PC+S. And we can see at months 48 post original implantation, with now the Percept device, we can see that same beta band peak at 20 hertz. This data not only shows that this beta band peak is consistent over time, but that it also is consistently sensed with both generation of devices. With the second generation PC, or with the first generation PC+S rather, with stimulation on, we see a very different picture. So we can see that our ability to sense meaningful electrophysiologic activity was significantly hindered by stimulation artifact. We can see that here in the raw time series, in which we see this oscillatory artifact that occurs at the stimulation frequency of 130 hertz and persisted despite low pass filters and numerous other digital post-processing techniques to try to filter out meaningful signal. We can see the peak here in the frequency domain at 130 hertz, and zooming into the beta band of interest at 27 and 13 hertz, we see peaks that are unfortunately stimulation-induced artifacts at the subharmonics of stimulation frequency. One reason we know that these are stimulation artifacts is looking at this frequency versus time plot, where a different color represents power. We can see the stimulation artifact at a roughly 130 hertz, as well as at the subharmonics of 27 and 13. And we know these are stimulation artifacts as it's a very consistent signal over time that isn't indicative of meaningful electrophysiologic activity. With the second generation device, the Percept, we were able to sense meaningful electrophysiologic activity. So we can see here in the raw time series, there was a recurring artifact every 5 seconds, easily removed with template subtraction. And then following low pass filtering, we can see here in the frequency domain at roughly 18 hertz, we see a beta band peak and we believe represents meaningful electrophysiologic activity. One of the reasons we think this is meaningful is that looking at the spectrogram, frequency versus time, we can see this burst pattern both to the beta band peak as well as at other frequencies, which is much more indicative of true electrophysiologic activity. All of this data was with significant post-processing and coding involved, obviously not necessarily amenable to adaptive deep brain stimulation. However, we also looked at what is possible with the device itself. And all of this data that I'm showing on this slide was programmed with the device and sensed directly from the device. And what we can see here is the summed or integrated local field potential power around the beta band of interest. Remember, we had that peak at roughly 20 hertz in the stim off setting. So integrating or summing the power around that peak between 17 and 22 hertz, we can see In blue is that integrated beta band power, versus in orange is the applied stimulation in milliamps. And we can see as we ramp up the applied stimulation above 1 milliamp roughly, we see this concomitant reduction in the integrated beta band power in blue. And this was consistent across multiple recordings on multiple different days and correlated with a reduction in Parkinsonian symptoms for the patient, including reduced tremor and bradykinesia, indicating that the meaningful biomarker of Parkinson's can be sensed directly from the device and correlates with disease symptoms. All of that is stimulation-induced artifact. Another potential source of artifact that we studied, and this was work published in Brain Stimulation, you may identify this complex as a PQRS T wave, which is obviously cardiac artifact. And what we saw in this work was that patients implanted with left subclavicular implants are significantly more impacted by cardiac artifact, roughly 50% of them, compared to less than 20% with a right subclavicular implant. And patients that had cranial implants had no cardiac artifact. And this was modeled based on the precise location of the IPG, the degree of cardiac artifact in the paper. Obviously relevant for any neurosurgeon implanting an IPG or replacing an IPG. So some discussion. Second generation bidirectional DBS systems can sense meaningful disease biomarkers, including beta band activity associated with Parkinson's during therapeutic stimulation. The adaptive DBS algorithm for personalized therapy in Parkinson's disease, or ADAPT-PD trial, is ongoing to assess the safety and efficacy of adaptive DBS using this Percept device that I showed. And that's shown here. Here are my references for my publications and a couple of additional references. And thanks to everyone at the STAR Lab at UCSF for allowing me to do this research. And of course, to everyone at UW for making this a really great month. And I've had a wonderful time, and I look forward to working with many of you hopefully in the future. So that's all I have, and I'd appreciate any questions anyone has.
Excellent. I see Jeff Ogeman is clapping. Any questions from our neurosurgeons?
That was a raised hand for a question.
Yeah. Oh, I'm sorry, Jeff. I apologize.
Who knows?
I stand corrected.
Which emoji I hit.
Yeah.
Thank you. In any of your analyses, do you see any evidence of volitional control and modulation with that? Because I mean, it's a really cool opportunity for the user to give feedback.
Yeah, that's not something that I looked at in this work, but it is something that people are looking at in the STAR Lab, for instance, is like gamma entrainment and trying to delineate volitional control of movement versus dyskinesias. There's a lot more overlap in kind of the dyskinesia side of thing for movement disorders, as obviously many of us know. You know, kind of distinguish a similar electrophysiologic character to dyskinesias compared to volitional control. Those are very similar electrophysiologically with a gamma peak compared to this kind of beta peak with the traditional Parkinsonian motor symptoms. So that's one thing that many people are looking at, but I didn't see with this patient in this work.
Thank you. That's a good answer to a tough question. Thanks, Jeff. Anything else? All right. Without further ado, that's very nice. Both Carlin and Daniel. Excellent. Let's go on to Sergio.
Hi, good morning, everyone. So I'm Sergio Guadix. I'm a visiting sub-I from Weill Cornell. Just a little bit about me. I'm a Cuban American, born and raised in Miami, Florida. On my downtime, I like to play guitar and played sports for a lot of my life, including 10 years of baseball. So really like to be active.
What position, Sergio?
Third base.
Excellent. I knew that. That's great. Craig Nettles there. There we go. All right. Go ahead.
All right, I'll go ahead and start sharing. All right. So, thanks everyone. I appreciate this opportunity to present a little bit about my research. So I'm going to talk about a project I've been working on during my dedicated research year as a part of Dr. Mark Soydan's translational lab. And specifically, we're looking at establishing a novel metronomic intrathecal platform for enhanced delivery of CDK4/6 inhibitors in pediatric brain tumors. So first, overexpression of cyclin-dependent kinases such as CDK4 and 6 has been cited as a major driver of cell cycle dysregulation and tumor proliferation in a subset of pediatric brain tumors. To combat this, CDK4/6 inhibitors such as palbociclib have been developed and have risen to the level of phase 1 clinical study. However, their translation has remained limited due in large part to variable CNS penetrance, which in practice leads to dose escalation, often incurring dose-limiting systemic toxicities. And taken together, this really paints a picture of an incomplete understanding of some of the pharmacologic aspects of these agents, including pharmacodynamics and pharmacokinetics, which we think warrant further investigation. So what we were particularly interested in the lab was finding a way to facilitate the translation of these promising agents to the clinic by understanding a little bit more about the pharmacokinetics and pharmacodynamic profiles and how these can be potentiated with direct drug delivery. So to that end, we first wanted to evaluate the need for long-term exposure to achieve maximal efficacy with these inhibitors in CNS tumors. We then wanted to assess the pharmacokinetic profile of palbociclib and how this can be potentiated through intrathecal delivery. And sort of combining these two aims, we wanted to demonstrate improved CNS drug residence and also a more preferable systemic toxicity profile when delivering palbociclib through intrathecal delivery compared with traditional systemic administration. So how do we go about achieving this? So first we started with drug screening and cell viability assays using several patient-derived cell lines and pediatric brain tumor subtypes of which you can see here. Then we explored the differences in short-term versus long-term efficacy when using CDK4/6 inhibitors in these cell lines. We then devised a platform for long-term intrathecal drug delivery in our tumor-naive mice, and this made use of commercially available osmotic pumps that we implanted subcutaneously and that allowed for cannulation of the right lateral ventricle to allow drug infusion over a chronic period of over 4 weeks. We then performed safety and toxicity experiments using different dosing thresholds of palbociclib and compared the systemic toxicity profile with systemic delivery, such as intraperitoneal injection, and how that compared with intrathecal delivery. And our main markers of systemic toxicity were elevations in creatinine, AST, and ALT that we trended throughout the duration of therapy. We then also performed pharmacokinetic assessments that allowed us to quantify concentrations of palbociclib in the plasma and in the brain, and how this differed with different delivery routes, both systemic and intrathecal. So first, use a snapshot of our in vitro results. So this is drug screening results in a ATRT cell line, and I'll have your attention here in the middle graph, figure B. So I'll walk you through it. On the y-axis is percent cell viability. X-axis is increasing dose of palbociclib. And each of these different colored lines corresponds to a different exposure period of drug that we incubated the cells with. So either 24 hours, 72 hours, or 7 days. And essentially what we found was that longer term exposure to palbociclib led to more drastic reductions in cell viability. And that's further highlighted here in this table where we have the IC50s. And we show a marked reduction in the IC50 of palbociclib going from 14 micromolar after 24 hours exposure, all the way down to 0.02 micromolar after 7 days exposure, thus suggesting increased potency with longer term exposure. So knowing this, our task was really to, one, increase the levels of palbociclib in the CNS, but also maintain those levels in the CNS for an extended period of time to optimize the efficacy of this agent. So to do that, we developed an intrathecal delivery platform to do just this. And these are just, this diagram here is just showing some surgical aspects involved in developing the platform. So that included burr hole drilling, aided by stereotactic coordinates, referencing bregma. And this allowed for cannulation of the right lateral ventricle. And then this ventricular cannula was then hooked up via catheter tubing to an osmotic pump drug reservoir that we tunneled subcutaneously and implanted in the interscapular region that allowed for chronic therapy over 4 weeks. So then the question becomes, how do we know that we're getting the drug exactly, where we need to get it? And so to do that, we filled our osmotic pumps with Evans blue dye, and this allowed us to visualize the distribution of our infusate. And so that's what you're seeing here in the sagittal hemisection to the right. What you can see is adequate distribution of Evans blue dye throughout the ventricular system. And this is further recapitulated on additional sectioning, most notably showing Evans blue dye spread throughout the central canal of the spinal cord. So now we're pretty confident that we're getting the drug, exactly where we need to get it based on our delivery platform. Now the question really is, how are we improving the pharmacokinetic profile by using this intrathecal platform compared to systemic delivery? So first, I'm showing you a set of graphs here, focusing on the top one. This is concentrations of palbociclib in the plasma compared to the brain after a single intraperitoneal injection. And so as you can see here, the levels of palbociclib markedly drop off from the plasma to the brain, suggesting pretty limited CNS penetrance. In graphing the concentration of palbociclib over time, we found an elimination rate of about 6 hours after a single intraperitoneal injection. So eliminated pretty quickly. So this set of graphs is corresponding to a single intrathecal injection. And essentially what we find here is the exact reverse relationship, where we have much higher levels of palbociclib in the brain, very negligible levels in the plasma, and again, about a 6-hour elimination after a single injection. So this last set of graphs corresponds to what we're able to achieve with a chronic 7-day intrathecal infusion using our osmotic pumps. And again, what we see here is much higher levels of palbociclib in the brain relative to the plasma. And then we're able to sustain this now on the order of several days, as opposed to an order of several hours, which we were finding with a single injection. So what does this mean in terms of systemic toxicity? As we just saw in the previous slide, we found pretty limited CNS penetrance when giving palbociclib systemically. And so as this might play out in the clinic, what we did in our mice was dose escalate to a higher dosing threshold of palbociclib. And once we did that, we started to incur systemic toxicities with elevations in ALT, AST, and creatinine, pretty marked elevations over, just a single intraperitoneal injection. Again, suggestive of systemic toxicity. Of note, this was not really shown when we were using our intrathecal delivery platform. So overall, what can we conclude from the study? So one, that long-term exposure is required to maximize the efficacy of CDK4/6 inhibitors in pediatric CNS tumors. And for our study, this effect was most prominent in our ATRT cell lines. Next, systemic administration of palbociclib is fairly limited in terms of CNS penetrance, and this creates significant barriers for clinical translation. Last, intrathecal delivery of palbociclib overcame these obstacles by one, increasing CNS concentrations, but also simultaneously limiting systemic exposure. So in terms of what we're doing in the future, we want to do survival studies in our ATRT xenograft mice. And all of this is with an eye towards translation to early phase clinical trials with a target population of embryonal tumors of infancy, such as ATRT, and tumors with leptomeningeal disease spread. These are just some funding sources. And of course, I'd like to thank Dr. Swaydan and the rest of the Swaydan lab for years of mentorship along the way.
Thank you. Excellent. Excellent.
Thank you, everyone. I appreciate your attention.
Any questions?
It's Christoph here. This was a really nice talk. Really enjoyed that. One thing that is interesting to kind of think about is, how that, diffusion would change in a patient that has indeed like a brainstem glioma with mass effect and obliteration of the CSF space, how that would diffuse there. And then how Dr. Swaydan, I know that when I was a resident there, they were thinking about in vivo pharmacokinetics. Is there anything that in that sort of realm that you guys are looking at?
So we're not looking at it explicitly within the context of this project, but some things in the pipeline include radio labeling of compounds that will allow us to, in real time, visualize the spread of the drug for a more sort of accurate, again, real-time pharmacokinetic assessment. That would allow us to, again, visualize volume of distribution and make any changes as needed with infusion. So that's a good point.
Thank you. Good. All righty. The next up is Nicholas Hugg from Stanford.
Hi, everyone. Yeah, my name's Nick. I'm from Stanford. My fun fact is that in my free time, I like to roast coffee when I have a chance, and mostly give it to friends these days, as I don't drink too much coffee on my own.
Thank you. Okay, we got it. Beautiful.
All right, great. So today I'm going to talk about my research in Greg Scherer's lab at Stanford studying the neurological underpinnings of opioid-induced respiratory depression. So opioids are the leading cause of drug overdose deaths in the United States. This graph from the CDC shows that this has been increasing over the past decade and far outstrips deaths due to other drugs like cocaine. And of course, opioid use is prevalent throughout the perioperative period. This study of analgesic prescriptions in 6 neuro ICUs worldwide found that 95% of patients are prescribed opioids at least once. And it continues into the postoperative period, with one institution finding that 85% of their post-op spine neurosurgery patients were prescribed opioids for more than 3 days on discharge. So given their prevalent use and their obvious efficacy, but also their potential for significant harm, understanding how opioids actually lead to overdose is extremely important for developing strategies to prevent these deaths. And death from opioid overdose results primarily from depressed respiration and subsequent hemodynamic instability, which is termed opioid-induced respiratory depression, or OIRD. And I've been studying this using whole body plethysmography to measure respiratory parameters in freely moving mice. And this measures airflow in a closed container from which I'm able to extract details about a mouse's breathing, like respiratory rate, tidal volume, and minute ventilation. So in this simple experiment, I've plotted respiratory rate over time, where mice are injected with either morphine or saline. And as you can see, the respiratory rate in the morphine group in purple drops off significantly compared to the saline group after injection. And now at a cellular level, opioids alter neural transmission via 4 subtypes of G protein coupled receptors: the mu, delta, kappa, and nociceptin receptor. And when activated, these cause hyperpolarization at neural synapses, decreasing signal transduction and neurotransmission. And so interestingly, all 4 of these receptors have been shown to be involved in pain modulation in some capacity, while the mu opioid receptor is the only one that's been identified as a driver for OIRD. So when you remove the mu opioid receptor from mice and administer morphine, you see that there isn't the expected change in respiratory rate or patterning that's observed in intact mice. And so because of this, attempts have been made to develop non-mu opioid receptor agonists with the hope of providing pain relief without respiratory changes. However, while some of these do spare respiration, most of these agonists have had their own harmful side effects and have not been widely adopted in clinical pain management. So in my research, I've been trying to investigate a couple of questions related to this topic. First, where are opioids acting in neural respiratory circuits to cause OIRD? And second, can mixed opioid receptor agonists avoid OIRD while providing analgesia? The first of these is important for guiding potential drug development. For example, if we could identify a single region or type of neuron that causes OIRD, we could potentially develop drugs that spare that area but maintain their effect on pain receptors. Or we could potentially develop a new antagonist to replace Narcan that only acts at these respiratory regions, sparing pain. However, identifying the neural location of OIRD has been complicated by the fact that the respiratory circuit spans the entire nervous system, though is primarily driven by the number of nuclei in the brainstem, shown here in a sagittal view. And these nuclei can be grouped into central pattern generators, patterning and modulating nuclei, and motor nuclei. And so I've been studying opioid receptor expression in these pathways using transgenic mice that express fluorescently tagged opioid receptors, which I can image to assess distribution throughout the brainstem. And one of my primary findings is that the mu opioid receptor is expressed diffusely throughout these respiratory nuclei, while other receptors are more sporadic. And a good example of this is in the pre-Botzinger complex, which is the central pattern generator that drives inspiratory patterning and has recently been a focus of much of the OIRD research. So here you can see in the coronal imaging of the mouse brainstem that the mu opioid receptor is expressed on a significant proportion of cell bodies within the pre-Botzinger complex, which is found underneath the nucleus ambiguous. The delta opioid receptor is also found on some of these cell bodies. However, there's little labeling of the kappa or nociceptin receptors. And crucially, I found that the mu opioid receptor is really expressed diffusely throughout the respiratory brainstem. It's found in central pattern generators, modulating nuclei, and motor nuclei. And what these findings highlight to me is that OIRD is unlikely to be driven by the actions of opioids at any one site in the brainstem, and rather it's due to the cumulative effect on many nuclei, making it a tough proposition to develop targeted drugs like I mentioned earlier. So moving on to the second question, can mixed opioid receptor agonists spare respiration while providing analgesia? And this is based on the idea that while single receptor agonists have not panned out, a combination may have a synergistic effect and provide pain relief without dangerous side effects. And so I've been collaborating with a chemistry lab that has developed one of these compounds that in their hands provides good analgesia without OIRD. And so I've been trying to validate that respiratory finding. One issue with the drug is that it doesn't cross the blood-brain barrier, so that lab has been injecting it directly into ventricles under anesthesia. In order to avoid that as a confounding variable, I worked with a postdoc in my lab to implant cannulas into the skull cap of mice, allowing direct access to the ventricle while the mouse was head fixed but awake. And I did some initial pain studies with that postdoc to confirm the analgesic effect of the drug. So here mice are placed on a hot plate and their pain behaviors represented by boxes are plotted over time. And each mouse is represented by one row. And you can see that when treated with the vehicle compound, the mice exhibit a number of pain responses that are rarely seen when treated with the novel opioid or morphine, indicating that this drug does have an analgesic effect. However, when I looked at respiration, I found that the drug did not live up to its initial promise. Here I'm showing respiratory rate as a percentage of the mouse's baseline vehicle respiratory rate. And you can see that over the course of the 3-hour experiment, the novel opioid and morphine resulted in a decrease in respiratory rate. Interestingly, morphine resulted in a significant increase in tidal volume over the course of the experiment, whereas the novel opioid continued to show a decrease in this parameter. And this ultimately meant that the opposing actions of rate and tidal volume caused the morphine group to recover their baseline minute ventilation after about an hour, whereas the novel agonist had decreased ventilation throughout the experiment. And so while this drug does seem to have some benefits from pain control, it also consistently results in OIRD. And so where do we go from here? Given that I found that there's unlikely to be one specific targetable site of OIRD, and that there's been limited success in developing novel, safe opioid agonists, I think there's a need for a transition in our thinking about how to continue to develop and use opioids in a safe way and what interventions might be possible. Something I'm currently working on is investigating the role of peripheral opioid receptors, which have been studied in the dorsal root ganglia and skin for their role in pain. But I've been investigating their expression and role within the vagal ganglia and carotid bodies, which are the primary source of feedback from the lungs and airway to the brainstem. And some of my preliminary data has shown that this may be a site for intervention to prevent respiratory depression following opioids. And while I haven't been able to fully validate the studies to this date, I think this highlights how there are still many untapped areas or approaches to thinking about OIRD management. And so with that, I'd like to thank my PI, Greg Scherer, for his guidance and for funding this work, Nicole Mercer-Lindsay and Will McCollum for their help with the experiments. And thanks to everyone for having me here on this rotation and for being here today. It's been a really great month, and I'm happy to take any questions.
Thanks, Nick. Appreciate it. Any questions?
Yeah, can I ask something?
Yeah, go ahead, Andrew.
Yeah, so I appreciate that trying to reduce overdose deaths caused by respiratory depression is like obviously it's a great thing to do that. My question is just kind of, does this perpetuate the sort of approach we take towards pain control with opiates, where we don't ignore the fact that it's not the addictive potential is not necessarily going to change if you change its effects on the respiratory system. Hyperalgesia as a consequence of long-term use. Are those things also kind of on the plate for being addressed if you're trying to develop, targeting these the opioid receptor for treatment of pain?
Yeah, absolutely. I think those are both big side effects of the drug beyond respiratory depression that people think about. There are a couple of people in my lab working on the hyperalgesia component. We're not as focused on addiction, just not within our wheelhouse so much. And I think with my thought with the respiratory depression component, we've talked in our lab a lot about the impact on patients in the hospital or in hospice who require a significant amount of morphine or other opiates just for pain management, especially in chronic end-stage cancer patients, and really focusing on making their preventing overdose in those settings, especially talking to some providers about how, people who have that kind of high of pain control needs will end up having overdose due to respiratory depression, and then you're giving them Narcan, and you kind of have this rush of pain back into their system. And so potentially having a way to avoid that would be beneficial for them. And so I think you're totally right that it's not a complete solution to the overall problem of opioid use and the concerns that we have for it. But it's a potential step in helping alleviate some of the concerns while we work on the other aspects as well.
Okay, Good question, Andrew. Thank you. All right. Without further ado, Derek Lewis from Mayo Clinic is our last speaker. They've been excellent talks this morning. Derek, go ahead.
Thank you. Good morning, everyone. My name is Derek Lewis. I'm from Mayo Clinic. As far as fun fact about myself, outside of wearing dress shoes, I only wear those toe shoes. That's pretty much the only thing I wear. So like, hopefully in the OR, I'll be mimicking Julian with his toe shoes. But yeah, I've been wearing them since I was 16 years old.
Okay, great.
So I'll be presenting on white matter changes in pharmacoresistant epilepsy, some research I had the privilege of doing at Mayo Clinic and the Multimodal Neuroimaging Lab. So to start, all research should start with a problem. So basically modern treatment paradigms fail 50% of epilepsy patients. A lot of patients, we can get good seizure control with AEDs, 70%. For those who aren't able to get control with that, we can identify epileptogenic focus. And half of those patients can get relief from surgery. But ultimately, there's a portion that we aren't able to solve their problems. We aren't able to get good control with 2 AEDs or with surgery. And so really, the thinking has shifted from a cortical lesion that you can cut out to having a network pathology and thinking about the white matter architecture. And so that's really where our research starts. So our goal was to understand the white matter architecture in epilepsy. Had 3 goals, or three methods to actually do that, which was to examine the white matter architecture, to develop insight into epilepsies and network pathology, and then hopefully apply those insights to the prediction of neurosurgical outcomes for different modalities. So first, I want to get into our method, which is a little wonky, but bear with me. I want to explain anisotropy and diffusivity. So if you'll notice, you have this image, this axial slice of brain on the right, and there is a CSF space, there's an inset there, and you'll see that these water molecules are diffusing isotropically, meaning in all directions. I know many of you are familiar with DWI, and this is the concept behind that. And that's the concept of mean diffusivity, where something is moving in all directions or moving in some direction. And anisotropy is a different concept where we're able to exploit the changes in how water diffuses and the directionality of it to infer white matter tracks. And so anisotropy would mean only moving in one direction or having some sort of asymmetry. And so this is really key to how we assess white matter tracks and their integrity. So I wanted to give a little bit more, make this a little more concrete as far as fractional anisotropy, which is a measurement of basically how much unidirectionality there is. And you see on the left, 0.012 is more spherical, more isotropic, whereas on the right, 0.82, it measures from 0 to 1, is more ellipsoid, is more linear. And so this is really to drive home the concepts, and hopefully that can help understand later on. So a method that we used was automatic fiber quantification. This is something that was developed by Even and colleagues at Stanford. And the innovation here is that traditionally, when looking at these white matter tract properties, you considered a single tract and averaged it. The difference here is that Even and colleagues, they actually had 100 equidistant points, and they measured fractional anisotropy and mean diffusivity along them. And so with this method, you can not lose all that data, that rich data that you have, as you consider different regions in the brain. And you can see here in these images, there are several different tracks they're looking at, and the colors correspond to different measurements along the tract. And so this was one of the methods we used, hopefully it being automated, leading to better clinical applications and less of just a research setting. So moving on to our study, we had 50 controls, 26 subjects. The subjects had a variety of epilepsy types. They were all non-lesional, but we're able to identify regions based on seizure semiology, video EEG, and MRI. 16 temporal, mostly temporal, that's the most common. 6 non-temporal, including multifocal, frontal lobe, parietal, and 4 didn't fit quite into any category. Maybe had 3 or 4 focuses. So going into what I actually did, I had first segmented the fiber pathways. So on the far left, you see a sagittal image of the whole brain connectome. And then the segmentation, B, was using the automated fiber quantification. And so you can probably identify some of these tracks, arcuvesiculus, you see the cortical spinal in green. And then last C is just an axial slice, so the same. So moving into our results, to orient you here, this is looking at basically the tracks that were ipsilateral to whatever focus was identified. And you'll notice that with here we have the blue, which is representing the patient's, controls is in black, and the only region where there's a clear difference, and this is looking at the shaded regions being standard deviations, is the uncinate fasciculus. And so we identify that the mean diffusivity has an increase in patients that have non-lesional pharmacoresistant epilepsy. We also looked at the contralateral side, and you'll notice that this too, similar organization to the previous one, where now green is for patients and black is controls, and the shaded regions represent standard deviation. The uncinate, although the signal is less robust, it still stands up to multiple comparisons, statistical analysis, that there is an increase in the mean diffusivity for the uncinate fasciculus. And so really, when I first was looking at this, analyzing the data, we were pretty excited about it and thought, man, is this a novel finding, especially with frontal lobe and temporal lobe epilepsy, as well as multifocal. I'll say that one other thing that we looked at were changes in FA, thinking that fractional anisotropy, mean diffusivity, they tend to have somewhat of an inverse relationship. But what we found here, you have ipsilateral on the left, contralateral on the right, and similarly, you have the black being controls and the colored ones being the patients, is that there actually weren't any differences in fractional anisotropy. So it seemed that mean diffusivity was slightly more sensitive. So I took a look back at the literature thinking, okay, this is a novel finding, this is interesting. And then we found that Keller et al., 2017, had published on something similar. I will say, though, the difference is that their patients only had mesotemporal sclerosis. So we still have a little bit of innovation here because we include patients beyond mesotemporal sclerosis. What they found, and to orient you here, ipsilateral on top, contralateral on bottom, they found that there was a huge difference. It's much larger than we had seen, honestly, in the uncinate fasciculus when it came to mean diffusivity. They also found a signal where they could kind of distinguish the patients who would ultimately most benefit from an amygdala hippocampectomy. They had the highest changes in MD compared to patients who had a suboptimal outcome with that same surgery. So they kind of introduced the concept that perhaps with our research, although it's more expansive, it's pretty heterogeneous, there is the potential to maybe infer what the outcome is going to be for different outcomes and counsel patients about the risk and benefits. So you might wonder, we had 16 patients with mesotemporal sclerosis. Maybe our findings are just driven by that cohort. Maybe it isn't the frontal epilepsy at all. And so we did that analysis. Here to orient you, we have MD on top, we have FA on the bottom. And in red, you'll see that these black lines represent statistical significance. Gray are the controls, and then we have ipsilateral, and we have contralateral. And we see that 60 to 70% of our patients, whether they're frontal lobe epilepsy, multifocal, or temporal lobe, have increases in mean diffusivity, at least a standard deviation above the mean for controls. So this is something that isn't driven by mesotemporal sclerosis, although that tended to have the highest signal. It's something that we see more generally. These generalized seizures are somehow affecting white matter tracts, specifically uncinate fasciculus, in a generalized fashion. So finally, I wanted to talk about the location of the differences, because you might think, hey, the temporal pole should be most affected in mesotemporal sclerosis. And we find that's not the case. It's actually sitting somewhere right in the middle, uncinate fasciculus, between the frontal and temporal pole, about 40 to 50% is where we find these greatest changes. And that's reassuring, because that tends to be where the AFQ algorithm is actually most accurate. And we see that it's most accurate in the middle. That seems to be where the changes are. It isn't really limited to the temporal or frontal pole. So finally, to drive home our key points are that temporal and extratemporal epilepsy have consistent changes in the mean diffusivity in the uncinate fasciculi. And it's something that's a novel finding. Previously only been seen in temporal epilepsy. These changes in the UF are more pronounced ipsilateral, but they are both ipsilateral and contralateral to the seizure focus. And so it's not just about what regions are connected to that seizure focus. There's something general happening with these seizures. And furthermore, mean diffusivity may be more sensitive than fractional anisotropy to underlying microstructural changes associated with epilepsy, which is important for future research in this space. So lastly, to our future directions, one thing we wanted to incorporate, because the uncinate fasciculus is known to be involved in the emotional valence of decision-making, we wanted to have neuropsych testing, and so that's something moving forward. We're gonna try to have neuropsych testing for all our patients before surgery, hopefully being able to get more insight into that connection between UF and whatever metrics we find. And then furthermore, working with Dr. Miller, we're using SEEG, trying to basically develop connectivity matrices so we can infer potentially which patients are going to benefit from surgery versus not, based on which hubs potentially in the white matter tracts are going to be most important. And so that's something that I'm bringing right now with graph theory, and stay tuned for publications on that. So lastly, I'd like to acknowledge the people without which this work would be possible: my mentor, Dr. Doris Erms Miller, Dr. Brinkman, Dr. Kai Miller, the generous gift of David Hawk and the Uline Fellowship, and everyone else at the Multiple Neuroimaging Lab. And I'm so thankful also to have been able to work with you these past 4 weeks. It's been a blast, and I look forward to work with you in the future.